Thank you. So healthcare needs a big, big, big and deep shot of design. And this is not just, as soon as I get this to work, there we go. So this is not just because of this. We have managed to actually build some of the most uninspiring and depressive places pretty much that our species have decided to build for people that need care. It's not just because of this. This is impersonal, sterile. There's nothing to do with what the people that are in that room are about to experience. We also need design in healthcare because of this. We don't live our diseases or the treatments mostly in the hospital, or surprise, or the doctor's office. We live them in our lives, at home, in places like this. And they take a big part of our lives, or our bedrooms. A lot happens around our conditions in our real lives outside of the healthcare spaces. We also need design because of this. This is one of the best hospitals in the world. We did everything right medically for that newborn. We cannot let that mother go out like that. And yes, we also need design in healthcare because of this. This could be the number of children that are obese. This could be the number of patients with diabetes. This could be the number of people with chronic conditions. This could be the care of healthcare costs, the costs of healthcare, you name it. We know where we were in the past. We have an idea of where we are today, and we have a very clear sense of where we're going in the next 3 or 4 or 5 years, regardless of the variable that you want to put in that graph. If you want to think of pharmaceutical productivity, you just need to turn the graph around. So how did this happen? How did we end up here? If you want the long story, let's go back 4 billion years. We have been basically designing different solutions for the environmental constraints that we encounter. That is what we have been doing. This is actually a bug that we grew up in our studio in Boston to do different design patterns. Now, believe it or not, healthcare professionals, many of us in the room, are not that different from these bugs. So I'm going to put a set of constraints to you, and we'll try to find a path to understand the solution. This is a patient that used a blood glucose monitor. And for all of those of you that this doesn't make you cringe, let me explain it. 100 would be, less than 100 would be good to have. When you have 400 on a blood glucose monitor, it's bad. Bad as in call a cab and go to the emergency room. In addition, this patient does not eat properly, does not exercise, has hypertension, and a bunch of other things. Those are all very important medical, scientific constraints. And some among you here and others have been training in the best possible schools in the world to identify them, do the right tests, ask some additional questions, and put a path forward. Often it requires a prescription or several. Now, that patient goes home and for the first time opens the package where more than 50 pages, needles, plastic bags, information, a CD, it's basically a pile this big, is about to be part of her life for the rest of her life. This moment is not medical, it is not scientific, it's highly emotional, it's social. She waited until there was nobody in her room, in her house, to be able to start her diabetes treatment. You can pick diabetes, it could be any other condition. Everything the doctors did to identify a series of metrics and prescribe a plan was done properly. But from this moment on, whether this patient continues with her diabetes treatment or not does not depend on that anymore. It depends on the experience that she's going to have from this moment on. And if we decide to give her this type of experience, it is not surprising that 30 to 40% of all patients that start insulin treatments for diabetes, drop the treatment in the first 3 to 4 months. Let me put it this way. You decide to buy something really important on eBay, and you find it and you order it. It's something that you want to get every 2 or 3 weeks or every month, and it comes in this crappy, cheap box with a bunch of pages and letters and a big data dump, and it basically makes no sense to you. It not only makes you uncomfortable, you're scared. There is no way you're going to order that again. Why do we think it's different in the healthcare space? So how did this come to happen? Well, let's think about these dots as interactions that this patient, this woman, had with her physician, nurse, healthcare provider. At some point she came in, she had a diagnosis, and they talked about it, and they made some measurements. 3 months later, she came in again, and they had a chat, and they shared with her some information. This is what's going on. 3 months later, she comes in again. There's another series of tests that are done. More information is shared. There might even be a threat. Unless you start exercising and eating healthier, I will put you on insulin, as many of you in the profession might remember stories about this. And then, at some point, we give her a prescription, and we hope. There are 2 things that are really important with the way we're doing this today. One, we are not paying attention to what happens between the dots. So it's an episodical approach. And what happens between the dots, whether it's like this or like this, is as important as the dots themselves. 2, we expect that by the time that we hand over that plan, that prescription, somebody else will take care of whatever comes after that, because we're done and we wash our hands. And no, we are not the sum of many isolated dots. Let me share with you briefly my life. I'll go very quickly. My life are a bunch of highs and lows. And you could put some together when I was a kid and when I was a teenager and as an adult. So I was delighted to go camping with scouts as I grew up in Mexico. And when I broke my arm, that was a low. And then we could go to a beach with my parents, and that was a high. For me, that first kiss was a high, might have been a low for some of you. Who knows? The breakup was a low. And don't want to make any assumptions. You get the idea. Now, those highs and lows have something in common. And this might look something similar to your life story. All of those highs and lows are anchored in very emotional moments. 1. Now 2, there are some lows that are really, really low. 6 years ago, I had one of the most difficult months in my life. My mom, who had previously had 2 open heart surgeries and had a stroke, her liver was failing, fell down and broke her hip. In the same month, we find out my dad has a brain tumor and we need to basically operate as soon as possible. We did everything we could medically. The medical constraint for which we were designing solutions was well done, was well thought, was well executed. Here's the diagnosis, here's the medical information, this is what you need to do. We did that. Now, identifying and solving medical and scientific technical constraints is just not enough for how we teach and practice medicine in today's healthcare space. It just doesn't do it. And here's where design comes in. This is one of my favorite definitions of design. Simple and elegant, powerful. It's a plan to rearrange elements with a purpose. This is by the American architect and designer, Charles Eames. Now, it has 3 parts that are very important. 1, there's a plan. We're somewhere here with an idea to go somewhere there, and somehow we know there's a path we need to get to. And we have different options on how do we go there. 2, we have a series of elements around us that we can use to get us there. Some of those might be physical, educational, digital, scientific, whatever those are. Just like that bug that we looked at a couple of slides back. And the 3rd one is purpose. And this is really important because in design, understanding what is it that you want to affect, how do you want to affect, is very important from designing an object to an experience to a space, anything. what is the purpose of healthcare? What is the purpose of us participating in the healthcare profession? Sometimes it feels like it's checking boxes and giving information in one direction, might be 20 pages clipped together. Sometimes it feels like it's following certain procedures to cover the legal liability options. Sometimes it feels like it's a short conversation. What is the ultimate purpose of the healthcare professional? And design can help us ask the right questions around that theme and hopefully answer some of those. So let me give you 4 examples of where I think design can really affect and is needed in healthcare. 1, how we experience medical products and services is as important as the actual product or service. On the left-hand side is a typical package of a product, different product for someone that is starting a treatment. In this case, diabetes, could be anything else. You open this box, in this case you have 58 pages, 6 different brochures with people laughing, kissing, fly fishing, whatever it is. You have legal mumbo jumbo. Granted, it has to be there. But there's nothing in there that has really been thought for this moment, where this data gets dumped in a highly emotional person. At this one moment, they're about to start a treatment for the rest of their life. We'll come back to that in a second. Now, on the right-hand side is the package where a Nike Fuel Band, just like this one, for those of you that don't know, it's just a simple device that measures exercise and movement. Every single thing in that package has been thought for the experience that I, the user, the consumer, will have. Now you might say, well, that's a consumer device and this is a medical device. Okay. A typical diabetes patient will spend somewhere between $1,800 and $2,200 for 5 years. So let's think of that value of a diabetes patient from a financial standpoint to a company. A typical Nike consumer will spend in that same time lapse 1/4. Device like this, $150, pair of running shoes, another pair of running shoes, a couple of t-shirts. Nike has decided to invest in how they engage their consumer, what experience they want them to have for someone that is worth to them, in financial terms, $500. And we still have not been able to design the right experience, even just in financial terms, for someone that is worth $2,000. It makes no sense. And the excuse of regulation is a cop-out, because there are ways to get around that. That's 1. 2, design can also help healthcare in a direction that is really important and taking on right now. We need to understand much better our personal phenotype and integrate that phenotype into how we study medicine, how we teach medicine, how we practice medicine, the services we provide. Phenotype, which is just the expression of information in our genes and the environment that we're exposed to, and the combination of those, is unique to us. We are patients with conditions. We are going to the person that goes into the hospital that has tests. We also are the enchiladas that we eat, the tamales we like, the crunchy, spicy food we like. We also are the exercise we do, whether it's a triathlon or swimming or running. But very importantly, we also are the points in between and what happens in between these stages. And that's the curve between the points. We need to do much better in tracking, measuring, and understanding the phenotype and how that changes in between these different moments. 3, we collectively need to figure out a way to value patient experience. And I'm going to ask you to first focus on the left-hand side. 2 quick examples. Every biopharmaceutical company decides what to have in their portfolio of drugs based on very few set of metrics, and this is one of them. Think of time and sales of a drug. At some point, a drug reaches what is called peak sales. And every biopharmaceutical company will estimate what those peak sales are, and then they will bring that value to the present through something that is called the net present value, and we'll make a decision of what to keep in the portfolio and what not. Kill this and kill this and keep and keep and keep and keep. With one big caveat, which is the sales of that drug does not include a drug or a service that could provide a great experience in how it communicates information, in explaining what the condition is, in a platform that maybe includes digital and physical assets to be able to talk with your family about so that others could support you in that. And that could actually affect significantly how many people stay in their treatments. So rather than having 30 or 40% of people dropping a treatment like an insulin treatment, maybe we can reduce that to 10% through having a better patient experience. If we were able to do that, maybe these curves would be much higher, but we don't do that today. Let me briefly switch gears to the right. In the right is an illustration of the cost of bringing a drug to market, regardless of what numbers you want to follow. It is a lot, and it takes a lot of time. But what we do know for almost every single drug is most of the cost comes when we enter clinical trials, the last 3 bars. Now, every clinical trial at least goes after 3 different metrics. 1, is the drug working? Is it actually doing what it's supposed to do? 2, is it safe? What are the different protocols that you're trying to complete? And 3, what might be some of the adverse reactions and other things that we learn along the way? Now, no clinical trial incorporates in how it's run a patient experience. Again, and regardless of where the clinical trial is run, in the US, in Germany, in Slovenia, or in Africa, can we affect how patients stay on a clinical trial by providing the right information, asking the right questions? Do they understand the condition? Do they know actually what they're taking? Can they have some tools and materials to talk with their family members so the family members can support them during the clinical trial? We don't do that. But we know that that can affect the medical outcomes of a clinical trial. Why don't we? Design could help with that. And we could also bring down the cost of those clinical trials. So let me move on to number 4. We deserve much better than fly fishing. And this is not just for the ad agencies, it's for all of us. We have grown accustomed in the healthcare space to have advertising for everything, to sell drugs in a way that is offensive. We need campaigns that grow awareness, that have a clear direction of what we can do. We need less advertising for selling. Let me come back to the story of my parents for a second. It is not a happy ending, but it's a very natural and normal ending. A year after my mom fell and broke her hip, she passed away, mostly because her liver was failing and she couldn't do all the things that she could do. My dad's tumor was gone after the operation, but he had a very strong case of Alzheimer's and is now in his sort of last stages. Now, we had very good solutions and design outcomes for the medical and scientific needs, constraints that we had at the time. Where healthcare failed for us is we had no elements, tools, platform of support for the emotional constraints, the social constraints, or the contextual constraints. We can't continue doing it like that. Collectively, we need to go beyond medical and scientific constraints. These are important, but it's not enough. We need to design for the emotional, social, and contextual constraints that we experience every day in our lives. We have the technology to do so. We have the capabilities to do so. We understand the importance of it. We just need to do it. I'm going to leave you with one line. Healthcare has the responsibility to treat patients, but that's only the first half. It also has a responsibility to engage people. The first one does not work without the second one. We need to design, yes, for treating patients, but we also need to design for engaging people. Thank you.